Good afternoon, ladies and gentlemen. Our webinar is beginning. My name is Steve Love. I'm President, CEO, Dallas-Fort Worth Hospital Council, and we want to thank all of you for participating in our webinar today. This is hosted in conjunction with Hall Renda. Hall Renda is an associate member of the Dallas-Fort Worth Hospital Council, and they are a year-round sponsor at some of our events, including Employee of the Year and our annual awards luncheon. Today's topic is hospitals under the microscope, the new scrutiny for tax-exempt healthcare. And we look forward to hearing the discussion today. As you know, government has ramped up scrutiny on nonprofit hospital spending. They've looked at different types of federal audits. They obviously look at Form 990 and Schedule H. And today we're just going to discuss some of those latest developments and some information that Hall Renda would like to share with you to help increase your knowledge base. Our speaker today is attorney Jeffrey Carmichael with Hall Renda. In his area of expertise is tax exemption with business services, and he advises organizations throughout the nation related to federal and state income tax laws, and this includes hospital clients as well, and health systems and hospital foundations. So there are many issues that continue to evolve. There are new requirements, and there are things surrounding tax status of entities. One administrative note, if you have any questions, and we hope you do during the presentation, please type them in the chat box or in the question box. And after Jeffrey finishes his presentation, we will certainly try to answer your questions. And I know we get questioned frequently, but today's presentation will be recorded, and for people that have registered, Chris Wilson will make sure that you get a copy of this webinar. And so with that, it's my pleasure to introduce to you Jeffrey Carmichael from Hall Renda.
Steve, thank you very much. It is a pleasure to be here representing my Hall Renda colleagues. For those of you who are not familiar with our firm, we are deeply engaged in all aspects of health law. My particular corner of that, as Steve said, is tax and tax exemption. And because so many of our clients, as I'm sure is true for you and the systems you represent, we work a lot in the realm of tax exemption. A number of for-profit clients as well, taxable clients, but a lot in the tax exemption space. Let me just start out with a couple of high-level introductory notes. I'm speaking not as a representative of any of the hospitals who are referenced in this presentation. I'm talking about things that are drawn solely from the public record, and I'm certainly not going to be commenting about any allegations and things that are in the public record as to whether they are correct or incorrect. I'm just letting you all know what is there. And so with that, let's talk about what we want to accomplish in this time together. Of course, we want to begin with a refresher, and for the taxable entity attorneys in the virtual room, and perhaps a little bit of an introduction to what exactly the standards are for tax exemption for healthcare organizations. Then we'll turn to this present scrutiny. And by present, I've decided to kind of start with the post-COVID timeframe. There is a very valuable presentation that could be done about sort of how did we get here and seeing the trends over time. But right now we're kind of on the front line, and so we really need to deal with that before we think about the historical context. Lastly, I want to spend time focusing on strategies that the tax-exempt hospitals and health systems can undertake in order to reduce their risk and even to convey a more positive appearance within the community as far as the significant benefits that they are offering. So let's get right into it. The rules of tax exemption, which I'm going to move through pretty quickly, but I'm happy to respond to questions about any of this as we get to the end. Core question, right? Does a tax exempt hospital have to provide charity care? And I'm using that term in quotes because you're going to see that's not really the language that is used in the realm of tax exemption anymore. But from a federal standpoint, the answer is no. From the standards that apply to tax-exempt hospitals and whether or not a hospital qualifies under Code Section 501c3, it's not about charity care, it's about community benefit with financial assistance being the current term, and that is relevant but not determinative. We're seeing the pressure though, and we want to talk about that. State-wise, we have different rules. We've got 50 states, and I'm going to say we've probably got 50 or 60 or more standards, especially when you parse those within different areas of tax, right? You talk about income tax, you talk about property tax, you talk about sales taxes, the big ones, and those standards are different. Sometimes charity care is required, not always. Texas, we're going to talk about, yes, it is important there, but it's not important everywhere. So we'll see how that plays out. Okay. Federal tax exemption, Code Section 501A is where we get the exemption standard. It says if you meet any of the standards within Section 501C, you qualify for federal income tax exemption for lots of categories, and where most of our health law clients land is 501c3, which in many ways is the most preferred status for tax-exempt organizations. I wanted you to have this. I'm not going to read it. I encourage you not to read it when you're about to drive a motor vehicle. It'll make anybody drowsy. But this is the exact language of 501c3. A portion is bolded, and you'll see why on the next slide, because you break down that language into 5 key elements here, of which the one that people really focus on and the current dialogue is centered around is this issue of the organization being organized and operated for charitable purposes. Now, I'm using charitable here in a broad way because charitable is both one of the subclassifications of 501c3 and is kind of used as a synonym for 501c3. So people talk about charitable hospitals, they mean 501c3 hospitals. These are the 8 qualifications, the 8 categories within 501c3. I've bolded the first 4 because that is where most of our hospital clients land. They are charitable, educational, and scientific. They recite that in their articles. Some are affiliated with religious organizations, so they add that. But those are the 4 main areas for why hospitals say they are tax exempt. What does charitable mean, though? Well, according to the regulations, it says charitable is used in its generally accepted legal sense, which is extremely helpful if you know the generally accepted legal sense, but otherwise it's a pretty opaque way of defining things. You get examples in the regulation, significantly including relief of the poor and lessening the burdens of government. Pretty important, though, that when you read the regulations, they don't mention healthcare. They don't say promotion of healthcare is charitable in the regulations. So how do we get 501c3 501c3 standing for these hospital clients? Well, for a period of time from 1956, the financial ability standard was the controlling standard. And although it had multiple elements, you'll see here, the main one is the second. It was necessary that to the extent of its financial ability, the hospital provide care for those who are unable to pay. And you go back to the definition of charitable in the regulations, and it makes sense. They're basically saying, you are a charitable hospital, not because you are providing health care, but because you are serving the poor. So relief of the poor being charitable, and a hospital that did that, therefore, is charitable. Well, that standard changed in 1969 to what we know now as the Community Benefit Standard. And we've all heard that phrase, a surprising amount in the public space now as people are really focusing on this. But the issue, first of all, the revenue ruling 69545 that announced the Community Benefit Standard, authored by the IRS, issued by the IRS. No congressional action was necessary as they made this clarification of how they're going to interpret whether a hospital is charitable. And they said, yes, we recognize that promoting health is a charitable purpose under certain circumstances. And so we're looking at whether the hospital's activities are beneficial to the community as a whole. Well, what does that mean? It means we're looking at a fact and circumstance test that looks at some specific factors, including whether there's a community board of directors, whether there is an open medical staff as opposed to a small group of physicians who control the hospital having the only rights to practice there. The emergency room, that was the big one for a lot of time. We'll talk about that. And that emergency room being open to all, regardless of ability to pay. Payment through private insurance or government programs or self-pay are the criteria for admission. And using those surplus funds not to declare dividends, but to improve the facility, improve the care that it is issuing. Now, this facts and circumstance test continues to be the driver. What we have is a bevy of facts and circumstances without any being essential. It's not you have to have all 5 of these things in order to qualify under 501c3. It's a matter of the IRS looking at everything that you have. Okay, the emergency room even no longer essential in some cases. What you'll note when you look at this is there's a pretty significant missing item in this list, and that is relief of the poor. It's not mentioned. In my view, and there's debate about this, but in my view, that is because 56-185, the financial ability standard, still applies. If you are caring for the poor, you're going to be deemed to be providing community benefit. So they didn't need it in this list, and including it might have skewed the analysis away from those other factors. Big sea change recently. Okay, so we've got two requirements that we're looking at for 501c3 hospitals. We're looking at the terms of the statute, we're looking at community benefit, and now we also are looking at compliance with Code Section 501R, which was added to the code by the Affordable Care Act. It applies 4 significant new requirements for hospitals: adopting a community health needs assessment every 3 years, along with an implementation strategy. Having and following a financial assistance policy, that's going to be a primary point for us today. Limitations on charges in relation to how much is billed to insured patients, and not engaging in what they term in the regulations and in the statute as an extraordinary collection action without first making reasonable efforts to determine if someone is eligible for financial assistance. All significant. But let's talk about the financial assistance policy because, right, the term financial assistance, I said, is the new parlance when we're talking about aid to those unable to pay. We don't talk about charity care in the code and regs. We talk about financial assistance. What is necessary in the financial assistance policy? It's listed here. And as you go through these requirements, you're going to see a lot about procedure and not very much about substance, because the regulations and the code don't set substantive requirements. They say you have to clarify what you have. They don't tell you what that has to be. No specific level of financial assistance is required, either as an absolute amount or as a percentage. And there isn't any effort in the regulations to equate providing financial assistance with 501c3 status in terms of how much benefit you are providing versus how much tax benefit you are getting. A few other elements talk about widely publicizing the financial assistance policy and the relationship of collection actions and the charges. So those elements are folded into the financial assistance policy very in procedural ways, but not in terms of having to spell out those things necessarily in the policy. We also note that 501R requires a review every 3 years of every 501c3 hospital by the IRS. To our understanding, based on what they have been saying, the IRS divided tax-exempt hospitals into 3 buckets. Year 1, they review all the hospitals in bucket 1. Year 2 for bucket 2. Year 3 for bucket 3. Rinse, lather, repeat, right? Every 3 years, they're getting to every hospital. We're going to talk a little bit more about the significance of those reviews. Now, feel like I'm at a dangerous point in this presentation right now, because I'm going to talk to a bunch of Texas lawyers about tax exemption in Texas, and I'm sitting up here in Indiana. So I have a feeling that those of you who work with tax exempt hospitals deal with these rules a lot more than I do in your state. So I'm going to hit them lightly. And apologies for any technical points that I don't get into that are significant to the analysis there. But, you know, when we're thinking about state tax, there are 3 areas that always jump to mind first: income tax or franchise tax, property tax, and sales tax. And in each case, Texas links exemption to providing community benefit or charity care. Both for franchise tax and sales tax purposes, there's a link to charity care and government-sponsored indigent care that is in the Health and Safety Code, and 3 different ways here that hospitals can show they are meeting that standard. 2 are specific numerical calculations. The other is a reasonableness standard, which I find interesting. Reasonable in relation to the community needs and the hospital resources. So that's a little softer standard, but you've got those 3 options. Then you get into property tax, and it cites to a different section in the tax code for what it means to be providing medical care without regard to the beneficiary's ability to pay, and that those citations are here. So that's part 1. That's looking at what the current standards are. Now let's get to what is new. right? We've got a lot of scrutiny happening, a lot of attention from a lot of different sources, and that's why we're here today, not to review what has been, but to talk about what is. So, whoops, there we go. I want to start out by getting right to the base of things and think about these assertions from the U.S. Senate, these committee hearings, these actions by the IRS, they all start with people. And in a lot of cases, they're starting with patients. It was interesting. I was working on this presentation last Sunday, and I took a break to go to the grocery store, and I turned on the radio, and the first phrase I heard just really struck me. It said, storytelling is a very compelling form of activism. Storytelling is a very compelling form of activism. And I thought that's it in a nutshell, because so much of what you're going to hear as we go forward is about these stories. And those stories are patient stories. And there's stories about patients going to hospitals and being charged for things they didn't think they were going to be charged for and maybe shouldn't have been charged for, or they are not paying afterward and all of a sudden they're being sued by the nonprofit hospital. So these stories are powerful, and you see people elevating those stories as we go forward. So we start with the patients. And we also have to take into account there is money behind this. There are people who are donating and funding efforts to implement change. So they're publicizing these patient stories. We see research around them. We see them asking the question of what the standards ought to be. And consultants and lawyers and accountants and others are chiming in about that, as are a lot of organizations. So we've got all of that leading into this issue of reform. I want to highlight one particular nonprofit organization that gets a lot of attention in this area, and that's the Lown Institute. Some of you are doubtless familiar with this. They issue a report every year about the level of charity care provided by tax-exempt hospitals, and specifically talking about whether tax-exempt hospitals are doing enough. And spoiler alert, the Lown Institute thinks they are not. And some of their statistics are here. They talk about things, though, in terms of a fair share shortfall. They look at the value of the tax exemption that the hospitals are getting, and they consider whether the hospitals are providing enough community benefit to warrant that exemption. In other words, is the benefit they are providing greater than the cost of the exemption? And in this organization's view, if the value isn't greater than the benefit, then something is off. And that position has gained a lot of traction. And in another annual tradition, right, as the night follows the day, so the AHA counterpoint follows the Lown Institute report. And you see executives from AHA or their president, their council, issuing a response each year. And they're pointing out the good things that hospitals are doing that are not taken into account in the Lown Institute's reports. Things like the Medicare and Medicaid shortfall and the overall benefit being more than a dollar-to-dollar comparison. So you get that. But all of this finds its way into the press. And by the press, I'm talking about industry publications as well as the more traditional press, which is writing more than they used to about this issue of community benefit. But still, you get more in the industry press about this than you do elsewhere. So out of that, the press and the patients and the Lown report and all of that lands on desks in Washington, D.C. And you get this really significant uptick in the amount of scrutiny right now of tax-exempt hospitals. You all know the players at the federal level, and you know them at the state level. So let's get right into it. And we'll land with a bang, right? Because again, focusing on the current, things really escalated in February of 2023. First with this letter from Senator Tammy Baldwin to Ascension Health. And I've got a quote from this letter here, and I'm including it because it is so visceral. It's such powerful language throughout the letter that shows, that really communicates some deep concern and even outrage over what is happening in the tax-exempt hospital community right now. You're going to see that trend, but this is the first time we're seeing it. But there is a reference right at the beginning of the letter to a report from the Milwaukee Journal Sentinel. And it shows that what you're seeing in the paper really matters in terms of what is happening in Washington. Okay, all of these points that are identified in the letter are highlighted in that newspaper article. And among them, you see a lot of emphasis in this particular letter about the system's investment activities and whether that additional revenue from investment is translating into patient care, and a concern that it isn't, that there are closures of facilities or service lines, particularly in less profitable areas. And this is a major thread that you are going to see time and again. This last point, aggressive collection practices. That's something that is resonating to all sectors of this review, and it's something that we're going to need to pay attention to. I said February was big. 1 week after Senator Baldwin's letter, Senators Warren and Wyden sent a letter to McKinsey and Company. Now, McKinsey isn't operating a hospital, they're contracting with one on the specific issue of debt collection. And they are trying to help Providence Hospital System with its collections. And they're doing so in some ways that Senators Warren and Wyden are concerned about. So again, collection practices. And they're talking about things where patients are not being informed, they say, about free care and other financial assistance, but they're being pressured to pay. And if they don't, they're being referred to debt collection or having other debt collection actions brought against them. Again, concern where in the view of these senators, they feel that a nonprofit tax-exempt hospital system is focusing more on profits than on patients. Senator Warren was not done at that point. This August 7th letter, she is joined by Senators Warnock, Cassidy, and Grassley. And you can read what they're talking about. They're getting specifically into the issue of whether the community benefit standard is the right standard. Here's something that I find really powerful about this letter. It's bipartisan. It's bipartisan in 2023 Washington, D.C., where the parties can't agree on anything except apparently on the community benefit standard, and except on an idea that nonprofit tax-exempt hospitals ought to be doing more or ought to be doing things differently. So you see these concerns that they are raising. Now, these are not specific concerns to a particular hospital. Note again, this letter is going to IRS and Treasury. So they flag things about some of the collection practices and also around issues of financial assistance and letting people know about financial assistance policies. But mainly, this letter is focusing on debt collection practices. But the concerns don't stop there. These senators also have concerns specifically about IRS and Treasury. They, in the senator's view, are just not holding up their end of the bargain. Lacks federal oversight. That's a strong phrase when you're at the IRS and the Senate is telling you this. They're concerned about the community benefit standard, and is it rigorous enough? And they're concerned that things are not clear in what the IRS is reviewing and what they are doing. So they are asking for action, not from the hospitals, right? The letters from Senators Warren and Wyden and also from Senator Baldwin are focused on getting information from the recipients of their letter. Here, these senators are asking for action. They want to see that the IRS is actively engaging in a review of its activities and focusing on tax-exempt hospitals in the right way. So now we've got one more from the Senate. We've got the Senate Health, Education, Labor, and Pension Committee. They didn't issue a letter. They issued a report. And they are concerned about whether tax-exempt hospitals are accountable. And this phrase is powerful at the end of the quote, offering charity care at levels consistent with the enormous tax breaks they receive. Right, here we go. We are equating the value of the benefits received, and specifically in the area of charity care, with the value to the system of the tax exemption. So what is this committee concerned about? You're starting to see some consistencies, right? The failure to publicize the financial assistance program, and yet again, aggressive collection practices. But let's not miss this, insufficient levels of financial assistance. Are tax-exempt hospitals doing enough? There is a pretty provocative statement from Senator Sanders, who is, he does know how to get the headlines. But if he says, if hospitals refuse to provide more charity care, they should lose their tax-exempt status. So he wants to make that equivalency explicit. Let's not forget, though, that we have a bicameral Congress. We have the other body, and the House has not been sitting on its hands. The subcommittee the subcommittee to the Ways and Means Committee held this hearing on tax-exempt hospitals and the community benefit standard, the kind of title that only a tax attorney could love. But they had 4 witnesses who, when you get into the reading in this area, you see these names a lot. You see that the Government Accountability Office is speaking into this area and urging action both by Congress and by the Internal Revenue Service. So the governmental component. You also see this academic component. G-Bai has done a lot of writing in this area, and she, based on her research, she does not believe that tax-exempt hospitals are doing enough. What they are doing is not sufficient for their tax-exempt status. KFF, Kaiser, is also talking into this space, and they also have policy recommendations for the IRS and for the Congress. So you've got three people kind of coming at it from one direction, and then Melinda Hatton as counsel for the American Hospital Association is talking about the very good things that tax-exempt hospitals are doing and why they do indeed warrant this tax-exempt status, even if it is conditioned on value for value. So you're seeing a lot of the same issues, right? You're seeing the trends of how care is being approached, or excuse me, how financial assistance is being approached. And you're also seeing consistently an elevation of financial assistance over community benefit, even though, as we saw early on, that's not the standard, but that's not necessarily the point in a world where perception can be reality. Now, we had a little bit of a shift when earlier this spring, just April 4th, there was a letter from 9 different members of the House of Representatives. And again, they wrote to Treasury and IRS, not to a specific hospital system. They were highly concerned about medical debt. I shouldn't jump over this. Who are those 9 representatives? They're listed here, and they're all Democrats. But I thought it was worth noting that they did channel a bipartisan spirit by quoting Senator Grassley, who, as those of us who have been in this space for a while know, has been very interested in tax exemption for hospitals for a long time. Anyway, going back to the core of their letter, they are focusing specifically and heavily on medical debts. And before everyone joined, Steve and I were talking a little bit about that as a significant issue that hospitals are facing all around the country. But they do not stop with medical debt, right? They bring up some of the same refrains we have been hearing elsewhere about the collection efforts and about the denial of care to patients with outstanding bills. So are you really benefiting your community when you do that? What did they ask for? Well, they asked the IRS and Treasury to strengthen the 501R regulations. They also asked for a new revenue ruling, right? Remember, the community benefit standard came out in a revenue ruling. It replaced the prior standard, the financial ability standard, which also came out in a revenue ruling. So this does not take congressional action to adjust this standard, and that's important, right? The IRS can do this in a binding way without both houses of Congress acting and without the president signing a bill. That's important to remember. So let's talk about those agencies, but let me pause for just a second on this to say things are, when we say in the title of this presentation, current scrutiny, we really mean it. I mean, this is brand new, fresh stuff, and this coincides, this IRS change in their review process and their prioritization of the various things on their plate. This is this spring, this revision, and they're focusing on the community benefit standard and 501R. And how are they going to do it? They're going to do it through examinations. In other words, audits. So they've updated their compliance program and priorities, as you saw on the previous slide, and they're going to focus on hospital audits. We think we're going to see more audits as a result of this. It's too early to say. We do know, though, that the information document requests, right? Let me talk about that for a second. These are the papers. They're standardized information requests that the IRS uses in this space. And they in each case, after they've done their initial review, they decide which are the important questions to forward to this particular organization, right? They don't send all of the standard questions to everyone. They figure out the questions that need to be asked. Well, the old information document requests are very mild compared to the new ones. There's a lot more detail being sought by the IRS. There is language about sending agents on site. A lot of the audits to date have been desk audits. No one travels to the hospital. The hospital simply provides the paper, and if that answers the questions, then the audit is closed. But these information document requests are getting more involved. So stay tuned, because this may be worth an update in the very near future. We've already talked about the GAO testifying at that House subcommittee hearing. Their recommendations as well, they come out in the hearing testimony, and they've also issued reports, and they're talking about what they want to see the IRS doing. So, excuse me, went the wrong way. States, it's the same refrain. It's the same issues that are getting attention. They're concerned about the level of financial assistance and also whether hospitals are hiding the ball. Are they telling patients about financial assistance? Are they making it easy or difficult to apply? And if they, once they receive care, what is the hospital doing to collect? Are they staying in bounds? And it's not only, I mean, we see it in terms of reports, we see it in terms of what legislatures are considering, and we see it in terms of what attorney generals are enforcing. So when the attorney general is bringing actions against hospitals about their financial assistance policies, it is very clear that we all need to sit up and take notice. So, that's a lot, right? There's a lot happening right now. And where are these things going to go? We don't know exactly how the systems that received letters from the senators, how they have responded. Those responses are not public. We have seen the IRS be prodded by the senators and say, yes, we're going to increase our scrutiny. We're seeing actions from attorneys general and state legislatures who are working on state rules in these areas, some of which, footnote, Texas is already ahead of, right? Because you're already linking community benefits and charity care to tax exemption in the areas of franchise tax, property tax, and sales tax. But we've got a big question, tax exempt hospitals. What are we going to do about it? How are we going to respond? So we want to add value. And so I want to go through and talk about how hospitals can respond. Okay. I've got this spotlight here to say, I think there are some areas where you want to try and stay out of the spotlight, and other areas where you really want to stand it in and you want to shine. Okay, staying out of the spotlight. We've seen these trends. We know what the what Congress is asking and other authorities are asking, and what are their main concerns. not having or publicizing a financial assistance policy, demanding payments for patients who ought to be receiving financial assistance, improper debt collection efforts, and overcompensating executives. I'm just going to say this. None of these things should be happening, right? None of them should be happening because on the last point, C3 hospitals have to deal with private inurement, excess benefit, and they have to be paying reasonable compensation. Excessive compensation is inconsistent with 501c3, and the other 3 points are flat inconsistent with Code Section 501R. When people are writing about these issues, it means that there's a compliance issue with the existing law, not a problem where we need new law. We just need to comply with what is already there. Some of these other areas are legal, but we are seeing such visceral reactions from government authorities and others that we need to think about them. We need to think about whether there is a problematic perception about profits being more important than patients. We need to think about our debt collection processes in terms of, yes, this is legal, but is it something a nonprofit organization ought to be doing? So those are the staying out of the spotlights. Let me hit 3 areas. I know I'm getting close to my time, so I want to be conscious of that. But I see 3 major areas where hospitals can be focused and can really, I want to say thrive, but at least survive in this current environment, okay? We need to double down on good 501R compliance. I think that starts with an internal audit where a hospital reviews what it's doing to ensure that it is indeed complying. And it is making the efforts to provide the education that people need in order to comply. In some cases, there may be change that needs to happen. Even though it's legally permissible, we have to decide whether it's consistent with mission. And I often, in training about 501R and educating about 501R, in the early days, I would talk about how you have the CHNA, the Community Health Needs Assessment requirements, and then you have these other 3 requirements that are kind of distinct in terms of where they land in the hospital. One is in the Community Relations Office, and the other is in finance. Well, maybe that's not the right way to think about it. Maybe there needs to be more explicit connection as we think about community benefit as a standard for tax exemption. And how are we benefiting our communities? It's not enough for us to say we benefit the community. We don't have to do charity care. That's not going to be the best messaging in this climate. We need to think more about showing that positive community benefit. What are we doing? How are we making a difference in our community? Well, we ought to be elevating the Community Health Needs Assessment as a mission critical document. We ought to be really thinking about it. It shouldn't just be something we complete every 3 years and then move on from. It ought to be a roadmap for us and a way that we can engage on whether it's issues like medical debts or particular sicknesses in areas of the hospital, the hospital's community. Those are things, and let's get credit for what we are doing. Let's promote community awareness of what we are doing, and then, right, the financial assistance. I've got it on the same line with charity care. Charity care is what we used to describe as helping those who are financially disadvantaged. The parlance has changed to financial assistance, but the message is the same. How does the hospital advance its mission by helping people in need? I think hospitals need to get ahead of this. I think that hospitals need to consider what their financial assistance is now and evaluate whether they ought to work to increase that and consider how they increase that. We can talk about where the money comes from. We can talk about whether hospitals can raise funds from the outside to help support them in their financial assistance efforts. However it needs to happen, let's make sure the communities are aware of it. Lastly, the first slide asked a question, right? Does a tax-exempt hospital have to provide charity care? I think in the current climate, that question has been answered for us, and it is yes. Okay, we're moving in that direction. So we want to think about how that can be something that we can use to our advantage in terms of advancing our mission and building relationships within our community and ultimately serving our charitable purpose. That is what I have, but we've got some time for questions, and I'm eager to hear what you all would like to ask.
Jeffrey, thank you so much. Great presentation. A lot of good information.
Thank you.
And, we'll watch in the chat and the Q&A box for questions. But prior to this, I received some questions. In your experience, and given the current scrutiny, as you indicated, federal and state level, do you think there are going to be significant changes coming down the pike to tax exemption standards for hospitals?
Well, yes, Steve, right out of the gate, you're asking a hard question, and I appreciate that. I believe there are going to be changes. Where are those changes going to come from? Right now, I think they're going to come more from the IRS than they are from the Congress. I do believe, I liked this phrase in one of the articles I read that talked about we have reached a bipartisan tipping point. I don't know if I agree that we have reached it, but I agree that we're getting close to it when we see this level of attention. I think if there were a congressional movement toward a significant piece of health legislation where this made sense as an amendment to that bill, I think that would be a possibility, but I don't see that coming right now. And the voices we are hearing from our folks in Washington is that they feel like this is the annual ritual that people get motivated, but not quite motivated enough to act. What is different, I think, due to the bipartisan demands is they are already triggering some IRS action. There is already IRS change, and it could be significant change, and it could grow. I think it is more likely that we would see a change in standard or a refinement of the standard from the IRS than from Congress.
Yeah, appreciate that answer, and it was a tough question. The next question I'd received, I think you really answered at the end of your presentation, but it's worth repeating. Do you recommend hospitals continue to address the widespread misunderstanding about the standard for tax exemption being community benefit rather than charity care, or should they now prioritize their hospital charity care activities? I think your answer was yes, they should.
Yeah, I think continuing to do both. I don't think we can rely solely on things that we've said in the past, like no margin, no mission. It's still accurate, but it's not necessarily enough at this time. I think for us to be able to say, we are doing both. We are benefiting those in need, and we are enhancing our efforts to do that while also enhancing our efforts to benefit our communities in visible and meaningful ways.
This next question I got is kind of like the old saying, trying to fly the airplane and overhaul the engine at the same time. What is your advice to hospitals on how they can best leverage their health initiatives so they certainly stay compliant with what they should for standards, but they know the public focus is shifting from community benefit to financial assistance? So they kind of are doing both. Do you have any advice on how to leverage that?
Yeah, I think right now I'm intrigued by the Texas standard because it allows hospitals to focus on both and to say we're spending this amount on community benefit, including this amount on charity care. So I think finding ways to, if we want to talk about leveraging, we want to talk about thinking from a community benefit standpoint about charity care. What do I mean? I mean a program like a mobile food bank, right? It's very clear when you're doing something like that, that is benefiting the community at large, but it is especially benefiting individuals in need. And so it's something that the community can look at, and they see your hospital logo on the side of this truck that is driving into disadvantaged neighborhoods and providing food at significant discounts or no cost at all. And all the time they're doing it, people are seeing it's your hospital behind that effort. And so, it's a nice intersection. It's not charity care that is medical, but it is social determinants of health type of community benefit that I think is very resonant today. And it's the kind of thing that when I see hospitals doing that, invariably you see the media talking about it. And I think that's a great thing to have in your quiver as something you can say when somebody says, what are you doing to provide relief to the poor? Well, have you heard about our mobile food bank? Just one example, but I think when we start moving into that space, that's where we develop our own stories, right? And remember, I think this is true both for patients, but also for hospitals and health systems. Storytelling is a compelling form of activism. Storytelling and getting our stories out, our hospital stories, is a great way of sharing the good that we are doing and telling that the authorities that the existing law is enough. We don't need new standards. You just need to let us do our work.
Right. There's one more question, but you've already answered it, and I'm checking the chat box and the Q&A box, and I don't believe we have any pending questions. But,
okay.
Jeffrey, I will tell you this. You mentioned medical debt, and I've been interviewed frequently, especially by KFF, where they've had a lot of articles on medical debt. And the one thing I can tell you about the 90 hospitals here at the DFW Hospital Council, and this includes, tax exempt, and we have some excellent investor-owned hospitals as well. I don't know of any hospital in the DFW area that uses any type of heavy-handed collection activity. Now, do they try to collect? Of course you have to. Medicare expects you to collect Medicare bad debt.
Yep.
But I don't know any that garnish or any that file lawsuits or any that, in any way use heavy-handed collection techniques. And I think that sends a good message as well.
I agree. And I think, again, to build a bridge between this question and the previous one, that's another space, right, where we can connect these community benefit efforts to our exempt status by saying, hey, we're working on this and we want to be part of the conversation. If it's not a problem in Dallas-Fort Worth, maybe it's a problem elsewhere in the state of Texas. It's certainly a problem, in other areas of the country, and being part of that effort only helps us to shine in the spotlight.
Right. Well, Jeffrey, on behalf of everyone that's on this webinar, we want to thank you. What an excellent presentation. We thank Renda for the support they give the healthcare community and specifically the Dallas-Fort Worth Hospital Council. I'll give you the chance for any closing remarks you'd like to make, and then we'll close out the webinar.
Boy, I thank you, Steve, and I thank your members. It's great to collaborate with you in doing something that, I suspect this probably came through. I get a little passionate about this, and it's funny that people look at me askance when I say I'm passionate about these issues of tax, but tax exemption ultimately circles back around to mission. And when you talk about tax exempt hospitals and how they are achieving their mission of ensuring that people receive high quality health care that allows them to live their lives without being under these ailments, boy, that's a great thing. And it makes me feel good at the end of the day when I get to go home and think about the good work that hospitals like your members are doing. So thank you. And thank you to all who attended. It's great to be able to talk to you, and I hope we can continue the dialogue.
Absolutely. Thanks again, Jeffrey. And with this, we will conclude our webinar, but thank you again for everyone joining, and I hope you have a wonderful rest of the day.
Thank you all.